What happens when you put a pelvic floor physical therapist and a podcast host, both absolutely obsessed with bridging the gaps in endometriosis care, behind the same mic? You get a conversation that finally makes sense of the messy middle, the parts of chronic pain that aren't always endo, the sneaky musculoskeletal pain generators no one's talking about, and the practical, doable tools that help you reclaim your body piece by piece. We're diving into why the delay of diagnosis creates long-lasting challenges in the musculoskeletal system and what you can practically do about it. It's validating, it's energizing, and honestly, it's kind of the conversation that makes you feel like someone finally turned the light on. And joining me for this powerful, joy-filled deep dive is the incredible Dr. Taylor Reyes, Doctor of Physical Therapy, board-certified functional manual therapist, chronic pain educator, and someone who brings both expertise and genuine heart into every word she shares. If you've been trying to connect the dots in your own endo journey, or if you've ever wondered, is this pain endo or is something else really going on? Or if you just love hearing two passionate humans absolutely nerd out about healing, you're in the right place. You're going to want to stick around. Welcome to Endo Battery, where I share my journey with endometriosis and chronic illness while learning and growing along the way. This podcast is not a substitute for medical advice, but a supportive space to provide community and valuable information so you never have to face this journey alone. We embrace a range of perspectives that may not always align with our own, believing that open dialogue helps us grow and gain new tools. Join me as I share stories of strength, resilience, and hope, from personal experiences to expert insights. I'm your host, Alana, and this is Endo Battery, charging our lives when endometriosis drains us. Welcome back to Endo Battery. Grab your cup of coffee or your cup of tea and join me at the table. Today, I am thrilled to be joined by Dr. Taylor Reyes, a powerhouse physical therapist whose work beautifully blends science, compassion, and true whole body healing. Dr. Reyes is a licensed physical therapist, doctor of physical therapy, and a board-certified functional manual therapist. She's known for treating patients from all walks of life, and for her passion in helping those with chronic pain shift their mindset, rebuild their trust in their bodies, and reclaim an empowered healing journey. Her approach is rooted in what she calls the pillars of healing: exercise, nutrition, and sleep. Her training is extensive and continually evolving, from gynecological visceral manipulation to advanced obstetrics and pelvic floor physical therapy, and board certification in functional manual therapy, a system that honors the intricate interconnectedness of every tissue and system in the body. With national and international experience and deep commitment to patient-centered care, Dr. Reyes brings heart and expertise to every conversation. So grab that cup of coffee, settle in, and help me welcoming Dr. Taylor Reyes to the table. Thank you, Taylor, so much for sitting down with me. I am such an admirer of everything that you do and all the work that you do for both the advocacy aspect of chronic health conditions and physical therapy and pelvic floor physical therapy and everything you do online. It's just been amazing. So thank you for sitting down with me today. I'm excited to get into this conversation.
Thank you. And I'm so honored. Likewise, like all of the resources you produce, I use them for my patients. Like, hey, go learn more
Oh my
on
gosh.
Endo Battery.
Thank you. That means a lot to me. That means a lot. One of the things that I love about your platform, and I've kind of told you this already, is just how not only authentic, but how much you advocate by not just going with status quo, like really inserting the facts of what you do and your expertise. Like, you don't let things go by the wayside for patients to figure out later on down the line that it's not actually what this influencer said to do. It's actually, there's something medical to it. I love that about you. I love how authentic you are. What is it that you do on your career side, and what has led that in social media?
Thank you. Yeah. So I am a pelvic floor physical therapist in Dallas, Texas, and my kind of background is in orthopedics. So initially, all of my professional training was pretty strong, heavy into manual therapy, orthopedic, visceral therapy, and then as my career grew, I started adding in the pelvic floor because we realized very quickly that it's like if you care about core function, you have to address the pelvic floor. You know, true core function is comprised of the diaphragmatic pelvic floor and spine stabilizer, basically like orchestra. so to speak,
Yeah.
their ability to work together appropriately. So, whether you're a shoulder patient that needs to throw something or lift something, you have to have good core function to produce good pressure management. Or if you're trying to pick something up heavy, or if you have pain with sex, which a lot of endometriosis patients do, what's going on that's perpetually creating tension in those muscles? Is it pathology or is it poor body mechanics? So all that to say, that's where we say orthopelvic therapy.
Interesting.
So we like to do a little bit of both. I've been practicing for about 11 years, and full transparency, I also have endometriosis and adenomyosis. I've had an excision surgery. So a lot of the information that I am presenting it is based in evidence. It is
Right.
objective, but there is some clinical and anecdotal experience woven in there, because kind of like you and I had chatted about before, like really truly how to manage endometriosis holistically, we're at the genesis of what the
Yeah.
research is or is not. There's across the board, we can say like, oh, well, there's no studies to support X, Y, and Z. And it's like, okay, well, the study just hasn't been done, you know.
Right.
Or did you use X, Y, and Z variable? Because one change in variable can completely influence what it is that you're actually finding. That being said, a lot of our goal in our clinic is to really help bridge those gaps between the orthopedic patients and also our autoimmune population and the endometriosis population. Because, yeah, endometriosis isn't considered autoimmune, but I always kind of cheekily say, like, if it walks like a duck, talks like a duck.
Yep.
Also, it'll probably just be renamed to something else completely different in 20 years, but that's future. So we have a heart for really working with the clients that, like we said before, have endometriosis, but they also have MCAS, like mast cell activation syndrome, POTS, postural orthostatic tachycardic syndrome, EDS, like Ehlers-Danlos syndrome, even craniocervical instability. Like those
Yeah.
types of patients come in, and it's like, what's what? So all of that's kind of a long way to say that in the clinic, I see a lot of different stuff. So a lot of my content is inspired by conversations that we
Mhm.
have. Because when we're looking at all of these complex cases, one of the big variables we have to consider is accessibility to care.
Right.
Because most of the providers that can really get you where you need to be, and this is not a blanket statement, but just in general,
Right.
might not be a network with your insurance provider.
Mhm.
So, okay, how do we live in a world where as a professional we can create good quality care for the people who are in front of us, but
Right.
how do we also get information out there to people so that they know, like, oh wait, I've been gaslit my whole life, which unfortunately comes with the territory.
Yep.
Or are there things, am I better equipped when I walk into a doctor's visit to know, like, hey, this plus this shouldn't equal this? you know on my Instagram page, my kind of tagline is talking about smart stuff in a silly way. Because
Mm.
when we're talking about chronic illness, chronic fatigue, disability, painful sex, trauma, like,
Right.
yeah, we can talk at it with a heavy heart. We can come in it with a sensationalized viewpoint, which I don't think is always the best thing, the most
Right.
therapeutic thing for viewers, to be sensationalizing content, but to just be like, hey, this kind of sucks, but like, what can we do about it? And hopefully it makes it more absorbable for the viewer.
No, I think that's true. I mean, like, we as people living with chronic illness, living in chronic pain, need hope. Like, we need a hopeful way of treating it because we get so many times we go to the doctor and we're like, I'm feeling X, Y, and Z. And they stare at you like a deer in the headlights, or they placate you with fancy words, but leave you with very little hope. And so, if there's direction and a hopeful direction, I think that's something that we can all grasp onto, which is something that I love. I feel like there's a lot of times you've hit content on your page where I'm like, that's me. And if you can identify yourself in something with good evidence based backing and say, this gives me direction, I just feel like patients are becoming way more savvy and they're looking at how can I better advocate for my care. And if they're given the tools to do it, I feel like their care by and large is much, much better. And that's why, like, for me, looking at your content and recognizing I'm familiar with that. Here's a tool, a like tangible tool that I can do or use to help me. That's hopeful, you know? And if you laugh along the way, great. Like that's
Right.
That's kind of what, something that I've always strived for, even with this podcast, is like, I want to make it hopeful. I don't want people
Yeah,
to feel more depressed leaving than when they came. I want them to leave with good
exactly.
information, something that's a tool to put in their tool belt and that they can advocate better for themselves in their care. And whether that care is at a physical therapist office, at their OBGYN, or any other practitioner, I think that we as a community want more information, but sometimes that's a lot of noise too. So we have to be careful with the information you know, that we take in, but there's evidence behind what you put out there, which is what I love. I love that you call that out too. It's
Yeah,
so
I like
good.
to think crunchy-based evidence or evidence-based crunchy because,
Mhm.
yeah, there's some stuff it's like, okay, just physical exercise is natural, it's crunchy, it's
Yep.
holistic, it's not a pharmaceutical, and we don't have to equate evidence with
Mhm.
pharmaceuticals, but
Well,
all
and
of
one of the things that I love that it's so because it's so tangible, I think it allows people to work on things that are out of the surgical realm
Mhm.
in maybe preparation for surgery or even after surgery or understanding their body better. And that's something that you and I have talked about is like there's this large delay in diagnosis, right? Like we hear 7 to 10 years. I think it's more. Personally, I think most people, it's anywhere from 12 to 20 years from
Yeah.
onset of symptoms. In my
Oh,
experience and
absolutely.
what I, you know, have talked to others about. So my thing about that is that I feel like we grow up around these chronically ill bodies. And I have experienced where, I've done the excision surgery and I've done pelvic floor PT but I'm also experiencing other musculoskeletal issues along the way, but it's because of the way that my body has for so long compensated.
Yeah.
And in your experience, in your practice, do you feel like the delay of diagnosis makes care harder for you to give to your patients when you have that?
Yes and no. And I say that from the perspective, so from the patient side, yes, the journey is more complex. From the clinician side, longer history where we can really take this 30,000-foot view and like see the history of bowel changes, bladder changes,
Mhm.
neurological issues, histamine intolerance, like all of these things, but also having years where they have tried different things and we can kind of say like, that didn't work, so we need to put that on the drawing board. It kind of helps us fine tune like, okay, yeah, we probably need to get you in front of a surgeon, or like because you've tried X, Y, and Z already. Because I never want to spin somebody's wheels and waste their time,
Right.
because pelvic floor therapy is very therapeutic, but sometimes it's, trying to put a wildfire out with a Dixie cup of water.
Right.
So, it's like, is if it works, great. If not, what else can we do? So
Right.
from the clinician perspective, sometimes it makes my job a little bit easier. But from the patient perspective, we are working through what has your brain developed as normal. Like, let's
Right.
look at it from the pain science perspective. So really three and this is general rules of thumb. I say this with empathy here. A lot of what is in evidence are guidelines and based on
Right.
averages. There will always be outliers. So if you hear something and say like, "Well, that's not me," that's okay. Like, this
Right.
is for some people it might be, for you it might not be. And cuz I wish we could create a perfect protocol for everybody, but we can't. So, we're looking at the pain science perspective. So if you have something going on for 3+ months, sometimes even shorter than that, the sensory part of your brain, like the sensory homunculus. I like to use the example of phantom limb pain.
Right.
It's a very 101 kind of watered down explanation, but for those who aren't aware of it, say you move your fingers, right? You're
Mhm.
sitting there wiggling your fingers around and you touch your fingers. There's going to be representation on your brain that's going to light up for each one of those fingers. So say you have your hand amputated for whatever reason. Just because your hand is gone does not mean those sensory pathways do not still exist.
Right.
They will be retrained, they will change, but for a period of time, sometimes a long time, you will still have those pathways saying like, "Wait, this is my finger." But it's like, "Wait, no, it's not." And a lot of times the brain can express confusion in the sensory side of thing or in the
Right.
neural pathways as pain.
Right.
So it's like, okay, when your brain has been accustomed to pain associated with different, whether it's just like in your cycle, right? It's
Mhm.
like especially if you have PMDD. It's like, okay, we're ramping up. This is familiar to my body. My body knows X, Y, and Z is normal. What does it look like to retrain that? The more years you have under your belt, that being the norm, the more difficult it can be. It doesn't mean it's always difficult, but the more difficult it can be. And sometimes people require different therapies for that. Sometimes it's just as simple as identifying the pattern because the brain is so powerful. And once you can, like, oh, I get that. Just like this is again, low hanging fruit explanation, but if you don't know you're in labor, you think you are dying
Yeah.
or pooping out a watermelon, one of the two, but it's intense regardless. So, but if you know you're in labor, like, okay,
Yeah.
I know what this is. And there's this there's a light at the end of the tunnel here.
Right.
And so your sympathetic nervous system does not go into fight or flight. Hey, we're being chased by a bear. Your cortisol levels are not going to spike the same way. Cortisol can be like gasoline on a pain flame.
Hmm.
So we have all of that. And then I think most of your listeners, viewers are very familiar with gaslighting and what
Yeah.
that can do to your nervous system. So, yes, like that's an element we have to consider, but also just from the physical standpoint, like, okay, weakness, muscular weakness can create pain. So,
Yeah.
how long have you been limited in your mobility that you have, or how extreme has your fatigue been? Because we know that fatigue is like
Yeah.
every single endo patient has fatigue to some degree. So, especially if you're a working parent or you're not a parent and you just work a freaking lot or
Yeah.
whatever the situation is, do you have like does the all of those factors lead up to where it's very difficult for you to have exercise tolerance and
Hmm.
then you develop weakness over time and that contributes to the pain. Not saying that if you strengthen the muscle that your endometriosis symptoms are going to go away, but it can contribute and increase the intensity of what you're experiencing. There's an analogy we use. I use it with runners often, but it's also for this, it works well too. If you're going to fire a cannon, would you rather fire a cannon off of a canoe or a battleship? Right? Like
Right.
our our physical bodies, like having strength, having stability, shout out EDS people because insert other barrier. But that's where we find modifications.
Yep.
So I also tell people like if you care about the strength of your pelvic floor, you care about your physical body first because if your pelvic floor is overcompensating for the lack of strength, and that's just in the normal human with or without a pathology, but say you have an overactive pelvic floor because of your endometriosis and your physical body is also literally just objectively weak, how much more strain, how much more dysfunction and intra-abdominal pressure are you putting on that body? Like
Right.
there are so many things to tease out here. And then we go into the neuromuscular issue, like how long has your brain known a poor compensation strategy? So is it actually something that's tight or weak or whatever, or is it compensation? So the more years of having this disease under your belt, the more things we have to tease through. And again, sometimes it can just be as simple as identifying it because the
Right.
brain is very powerful and it can click. Or sometimes it's just we identify it and then it takes about 3 months for the body to really like with strength training, with training new postural habits, training new anything to become automatic. It takes about 3 months with consistency.
Yeah.
So, what are we looking at there? So as we start to tease through symptoms, because symptoms are very subjective with endometriosis, and there's a lot of things we have to consider. So, and then also scar tissue, right?
Hmm.
So, like just in the pure mechanical sense, how long have the inflammation, the lesions, how much have they been impacting your fascial systems, your musculoskeletal
Hmm.
system? Do you have a crazy neural tension? Like, does it feel like you have a disc issue that's causing your leg pain, or is it scar tissue?
Right.
And even then, I mean, that's even when we can kind of go into post-surgical management. Like say you have significant endo on your bowel and you have that excise, not necessarily, I'm not talking about bowel resection here, which that could apply, but if we're
Right.
just talking about like the rectovaginal pouch, especially, so you're used to having adhesions there and now you have scar tissue there. It's therapeutic scar tissue. Like it would be awesome if we could do surgery without creating scar tissue. But the fact of the matter is there will always be a certain degree of scar tissue. So now the pain that you're feeling Was it those decades of having restrictions on your bowel, or is it just you're restricted, but not because of the endometriosis, but because of scar tissue? And do we have to retrain that, right? Do we have to work on
Right.
being able to lengthen the pelvic floor? Do we have to work on improving your fiber so your
Mm.
rectum isn't taking such a beating every time you have a bowel movement?
I'll give you a really clear example of like exactly what you're talking about, and something that I've explored personally is the fact that because I've had, two C-sections, I've had laparotomies, I've had everything, tons of scar tissue, right? Like when that starts pulling in, it's really hard to differentiate between back pain from something else, or is this just scarred tissue? From a personal perspective, I can tell you, like, as a patient, it is really hard to differentiate your signs and symptoms when you're going into a provider trying to figure out what's hurting. What is, like, yeah, I know I have pelvic floor dysfunction, but there's other things that are bothering me too. How do you, as a clinician, manage that with your patients? Because it's overwhelming to walk in with symptoms that don't seem to resonate with one pathology or another. It just seems like a gumball jar of things,
Mhm.
like take your pick. You might get a blue, you might get a red. We
Yeah.
don't know.
Yeah, it's fun, kind of exactly what you're saying. So there's, one way that I manage it and our team, like my whole team manages it this way, is sometimes with those cases, we literally pull up a dry erase board and we write down
Mm,
every single symptom they're experiencing. And we take a green marker and we say, this represents endometriosis. Check, 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 check. This blue marker represents scar tissue. Check, check, check. This red marker represents EDS symptoms. And we go through and kind of tally so they can kind of see like,
right,
okay, we're dealing with a lot of stuff. And then really fine tune what symptom bothers them the most.
right,
Because you can walk in with 1,000 symptoms, but you're like, okay, maybe your lack of hip mobility limits your function the most physically, but the
right.
patient's goal is just to be able to poop better. So it's like
Yep.
there could be like objectively what's the worst, but subjectively what do I care about more? So we kind of look at this broad sheet of things to figure out what's really driving all of this. What do we
Mhm.
want to work on the most? And then this is our plan. But I do feel like with a case like that, which we see a lot of, one of the most important variables is saying like, I do not know with 100% certainty what is causing this exact symptom.
Right,
Sometimes it can't. I mean, sometimes we do know that, but the transparency and the open dialogue with the patient is really important because at the end of the day, they need to be a part of the rehabilitation team as much, if not more, than the therapist because
right,
it's their body and what if they move states, right?
right.
Or what if they can't afford therapy, or what if I'm like, peace, I'm going to Bali. I don't know. Like, what if they no longer have access to care? Like
Yeah.
this shouldn't be information that is being gape yeah, that yeah, by the provider, right?
Right.
So they should be able to access their own care and reproduce it, or at least be the facilitator of it with somebody else if they
Mhm.
need it. So that transparency and that dialogue is incredibly important.
Mhm.
And kind of just a little other caveat, you're saying that you've had, people would come in that's had multiple surgeries. Is this
Yep.
scar tissue? Are these lesions? What's going on? Hey, I've already had excision surgery.
Yep.
So in theory, we should be able to check endometriosis off the box. Not necessarily, because it
Right.
really, and I hate to say this, but just because it's a fact doesn't mean like I'm just the messenger here. Who was your surgeon? Because excision surgery is becoming very trending, and a lot of people are happy to say that they're an excision surgeon. But what you need to look at is what are their patients' long term outcomes? And unfortunately, that involves a lot of footwork on the patient's part. But it is what it is right now. And I will say there's resources out there that say that they are the hub for endometriosis advocates and surgeons and therapists. Um, no, and I'm not referring to Nancy's Nook. Nancy's amazing. I love her.
Yes.
I will stand behind her every day, all day. But there's other platforms out there, and like
Yeah.
even as a therapist, the ability to get on that platform, the only thing that allowed me on there was the honor system. Like there was
Mhm.
actually no true vetting. Like open book test. It's my word whether or not I've seen patients. And looking at that list, I can look at other therapists and say, like, they are not specialists. So to go back to say, like, did you have the excision surgery? I know that can feel aggressive. Like
Yeah.
if you're sitting there, you had excision surgery, and I'm not necessarily talking about a really like category 4 deep infiltrating, stage 4,
Right.
however we want to refer to them. Not necessarily like there's outliers here, but I'm talking about like, well, I had excision surgery with this guy who said he's a specialist, in about a year it started coming back. And it's like, I can hold space and acknowledge like that sucks to try to process that possibly the surgery I had did not actually do what they said. But it doesn't, like, just because it sucks doesn't mean we shouldn't look at it as a variable.
Yep.
And unfortunately, right now, it's really hard unless you vet the heck out of your surgeon, like make it a part-time job. It's really hard to know what you're getting. And then, like we talked about before, just the way the healthcare system is set up, a lot of times the surgeons that we can kind of say with confidence are where you need to be are in a network.
Right.
I had surgery with an out of network provider. I get the burn. I understand the
Right.
burn, and the burn can be different for everybody. But all that to say, there's a lot of layers to managing acute. Like, hey, I'm at the beginning of my endometriosis journey. And then there's the endometriosis veterans. Being able to manage across the board is really complex. But I think, again, transparency and honesty within yourself and is within the provider is the most important thing.
Yeah. And I think one of the things when, we were talking about like the surgeons and kind of vetting your surgeons, which mind you is very hard because just because they appear to be great either on social media or they have great bedside manner doesn't necessarily speak for their skill level. And that's a
Mhm.
really hard thing to differentiate as a patient, right? Is their skill level. So when you're seeing a PT, like it's important to still talk about that being an option, even at the highest level of surgeon. Like it is always on the table. Doesn't always mean that it's the reason for your pain or persistence of pain. I think oftentimes persistence of pain is something else usually that we haven't addressed or even recognized. Like for me, and I can only speak for myself on this, is like I went into my excision surgery thinking that once it was done, I was going to be magically cured from every pain that I had. Let me tell you just the amount of like emotional trauma that caused me later on that I'm still dealing with in a lot of ways because now I'm having to see doctors for all of these other variables that I didn't expect or even think of or even know about when I had my surgery. I mean, I had my surgery in 2020, so it's been a little bit. And so I think one of the things that I've worked on recently and something that I encourage people to do is come up with a care plan map. So like mapping it out, which is kind of what you're talking about is like you are mapping out not only the signs and symptoms, but what would that care look like? Like realistically, is this achievable to be completely pain-free? For me, I can tell you I will probably never be 100% pain-free, but can I have a better quality of life? Like I think there is that expectation that we have to kind of set realistically in those rooms
Mhm.
too. Do you do you feel like in your practice and what you've experienced, do you think patients have that expectation of like complete healing or are they coming in leery? Like what do you typically see with these patients?
Yeah. I there is so much hope that goes into getting surgery in general, like being willing to have surgery, but two, when we finally reach the excision specialist, when we finally reach the person who we have vetted, it is really difficult to not say it's my time. It's
Mhm.
it's time to feel better. I am so tired of this. I actually had a patient the other day. She had surgery by a great surgeon, or I should very skilled surgeon. And immediately, and I know she wouldn't care if I shared I'm not sharing her identity, but just some tidbits of information. She's a hairstylist and she
Mhm.
stands a lot. And her
Yeah.
primary symptom was hip pain. Not period pain, not pain with sex, which she realized she was having pain with sex, but not till after the surgery when she realized, oh, this is what sex is supposed to feel like. After I saw her for a couple months and, she was responding like, yeah, okay, like, yeah, this is kind of getting better. Like, we can't take out the repetitive activity of standing because that's your money generator. It's going to take a little bit longer for this hip pain to get better. But finally, it was just like, between the lifespan of this hip pain and the little bit of constipation you have and the general fatigue and anxiety levels you have, let's go get a consult. So
Yeah.
she got a consult, did a surgery, and it's like that hip pain gone.
Yes.
100% gone. But again, as we uncover like the loudest pain in the group,
Yep.
other things can start to pop up. And so she's like, we had this conversation at maybe like 7 or 8 weeks after her surgery. She was saying, "Hey, I noticed a twinge here," and she got a little misty, and she's just like, "I just wish I could unsubscribe to this. Like, I don't want this
Mhm.
content anymore." And I was like, "That's a really great way to say it because
Yeah.
it's like we come out like, yes, this is gonna help us. We're gonna be here. And then you do notice it does, but there's still other things because endometriosis sits in a body with multiple systems.
Yep.
There's multiple possible pain generators going on. There's multiple possible constipation generators. And I say that because a lot of endo patients deal with constipation.
Yeah.
There's multiple avenues to have bladder urgency, anxiety being one of them, or even just the scar tissue healing. I mean, scar tissue takes about a year to really mature, sometimes a little bit longer.
Right.
So as you heal, like you kind of have to address the scar tissue in different ways. And, some people will poo poo that, some people don't. So it's like, who do you want to listen to? So, in the sense of like everything's going to be better, it's like, okay, well, did you, and this is where we kind of go back to the conversation about how long have you had
Right.
endometriosis undiagnosed? Are we now also dealing with pelvic congestion syndrome?
Mhm.
Is there a vascular issue going on that's creating symptoms almost identical to
Yeah.
endometriosis? So it's like, and it's a not hard, but it's a heavy place to help walk your patient through that,
Mm.
to kind of be able to hold space for them as they have that revelation that things aren't going to be perfect
Right.
and that this is a process. I use this analogy with my patients that endometriosis is like a tornado,
Mm.
and then the excision surgery is the tornado going away. And then
Mm.
after surgery, what you're doing is you're doing the cleanup. You're
Yep.
getting rid of all the trees that have been broken down. You're repairing the houses that got torn down. You're, repairing the schools. You're cleaning up the debris. We live in Tornado Alley, so that's like an easy analogy for us, but it's not done. Surgery is like just the beginning.
It's a
Or
step in it. Yeah.
maybe a pit stop, because it's
Mm.
definitely not the beginning of someone's journey, but it's an important factor, especially to getting that huge load of inflammation down. I use this example with my shoulder patients, especially like we don't like, steroid shots are very controversial in orthopedic care. But if you cannot lift your arm up at all because of the pain, sometimes you just need some steroids. PT first, but sometimes you got to load yourself with steroids so you can actually do the exercise. So it's similar, like, I mean, just again, low hanging fruit example, but cutting out all that junk so
Yep.
that your body can actually take a breath and get a second wind to say, like, how are we going to recover from this? So, and every once in a while, I'll have a patient. A couple months ago, I had a patient who, when I wrote their eval note to their surgeon, a couple weeks before she had surgery, I was like, I even wrote in the assessment, like, okay, patient presents with classic signs consistent with X, Y, and Z. But I made a note like, hey, this patient, if GI bowel bladder symptoms have not improved within 8 to 12 weeks of surgery, it is recommended that they see a gastro specialist and or nutritional counseling and have testing for SIBO and H. pylori. Like I was convinced. I was
Yeah.
convinced that they were not going to get the relief they needed. And this sweet person comes back a week after her surgery and she's like, "Oh, my GI pain is gone." And she's like, however many, like it's been months and she's still amazing and like needs zero therapy. And I'm like, wow, that was a learning lesson for me.
Yeah.
I didn't see that one coming. So every once in a while we'll have people who are just like, "I'm amazing." And I'm like, "I'm so happy for you."
I've not experienced that, but I'm glad that you
No.
have.
Yeah. Yeah, and I mean, the even anecdotally, like, I'll tell people I shared this briefly, like, I had my surgery, and then 2 weeks later, I had my excision surgery, 2 weeks later, I ended up with a blocked bile duct. So, insert 3-week story of, like, me being in the hospital for a week, having an emergency gallbladder removal, and they had to go in and, like, cut open my bile duct. Turns out that duct had been scarred for years. I'd been telling doctors that I was feeling this pain, especially after I'd eat, but they said it was stress and anxiety. And my liver is, like, misshapen, because of how scarred it was, all because of poor motility. So kind of even going back to the
Mhm.
conversation of like how long, like the longer you have this, but that's not something we can address in pelvic floor therapy because that's like part of the gastro and like that's organs
Right.
that's not our scope of practice necessarily. That's like honestly partially stress management, addressing things nutritionally because there's
Yeah.
not really you can't do a scope for that. Like, what are you going to do? I'm not. My point is like I'm not the only one with those types of experiences.
Right.
It's like you have the surgery done, and then it's like, oh, this is hanging out also.
Right. Well, and like, and what you were saying in the pain science aspect of it too is like, we can have the surgery, but if we don't address some of that pain science, where the pain generators are coming from, whether that's because our brain is so used to feeling that pain that anytime we get close to it, automatically we're going to like think we're feeling this pain, right? Like, how
Hmm.
do we differentiate that? And I do think therapy is a huge part of this process. And that's
Hmm.
something that I've experienced in my journey is being able to be open and having therapy mixed with my physical therapy because I
Yeah.
do think that they play hand in hand a lot. And I don't know if you've experienced that with you or with your patients. Like I think there's healing to be done simultaneously between the two
Hmm.
or in
Hmm.
tandem.
Yeah, absolutely. And so I wrote an ebook called The Endometriosis Solution a few years ago. And spoiler alert, there is no one solution. But it's really, it's just meant to be a rapid fire resource. It's time. I need to update it. So don't go buy it. I need to update it because there's so much new
There's
information out
so
there,
much
right? It's like, who has time? Just follow my Instagram. But what I will say, because we do have those patients who, whether they have had surgery or maybe they don't want to have surgery
right.
because of finances, because of lack of support, because I do work with a lot of patients that are very deeply in the natural, holistic world that do not want anything to do with the medical community. And I will respect that. So, how do
Right.
we serve the person in front of us? Not the condition, but the person. So, if we were kind of, again, to kind of take this 30,000-foot view, how do we serve somebody who is either still struggling or doesn't want surgery? The three pillars that I talk about are down regulating your nervous system,
Hmm.
meaning, how do we teach your body that you're not being chased by a bear
Right.
all the time? And then how pelvic floor therapy, right?
Hmm.
Because we are training the physical body. And this is where we can kind of reinsert how do we find modifications for our mobility limitations, our energy conservation limitations, et cetera, et cetera. And pelvic floor therapy does not necessarily have to be intravaginal or intrarectal therapy. I have plenty of patients where we may assess the first visit internally, but we can absolutely create a plan of care that does not involve going in any orifice.
Right.
So, because we have to have that for people
Right.
who, anyway, so there's the pelvic floor therapy to retrain the body, to retrain muscle patterns, to even do visceral mobilizations, like for lack of a better word, just mobilize the guts because it can create, and whether or not, like, again, there's people who poo poo manual therapy. Fine, you do you, boo. Like they can live they can live their happy manual therapy free lives. But what I will say that what
Yeah.
patients keep coming back to us for over and over again is the visceral mobilizations
Yep.
because there is therapeutic value in even just feeling better even if it's not fixing the issue, because mobilizations will not fix endometriosis. It does not fix scar tissue, but it can reduce the pain associated with it. And that's
Right.
what we care about. So, and there's also a study, the level of evidence in this study is like, it could be better, but Rice et al., it's like 2011, and it talks about it's a 10-year retrospective study on specific manual therapy to the reproductive organs and how it improves pain and fertility related to endometriosis, how it can improve the efficacy of IVF, PCOS. Like, I mean, it's kind of wild. And so and by skilled manual therapy, I don't mean about just doing like a general like abdomen massage. I mean, we're
Right.
talking about specificity. So again, when you're vetting your therapist, just the same way you should vet your surgeon, you need to ask, like, where is their training from?
Mm.
So that's where I'll say, like, we operate through our orthopedic manual therapy training is functional manual therapy. So there's the institute for, so if you're
Mhm.
searching for a therapist, there's the Institute of Physical Art, IPA, and you can be IPA trained or you could become certified as a certified functional manual therapist. They
Okay.
really get into the weeds about specificity with total body manual therapy, and they have a visceral mobilization course as well. So all that to say, it's like, well, manual therapy didn't work for me. I'm like, well, maybe you had bad manual therapy. I don't know. Or, maybe it just doesn't work for you. Either way,
Yeah.
I try to encourage people not to throw the baby out with the bathwater.
Right.
with an N of one. So going back, circling back around to, we have down regulating the nervous system. We have pelvic floor therapy, which can involve a lot of pillars. And then I'm trying to decide how I want to say this because I don't know that I love this title anymore, but like an anti inflammatory lifestyle.
Right.
Because it's like inflammation can be different for every person. It can be more food based, it can be more home endocrine disruptor based. We know that a lot that products containing endocrine disruptors can obviously disrupt the endocrine system, but
Right.
is there research like really strong evidence saying that an endocrine disruptor is going to increase your endometriosis symptoms? I'm not going to say I'm just going to say I
Right.
haven't seen it. I'm not going to say
Haven't
it
seen
doesn't.
that.
I'm not going to say it does, right? Like I think it's something kind of like we don't need a study to tell us that the femur is connected to the tibia. Like we just know that. And
Yeah.
A plus B equals C, we can say like, okay, let's take that into consideration. So if it's not going to put us into financial despair to buy products that don't contain endocrine disruptors, like let's do it. You know what
Right.
I mean? It's like, let's live that anti-inflammatory lifestyle. But fact of the matter is it can be a little cost prohibitive to some people to
Right.
really like, because we can get into food deserts. We can get into even just not just the food deserts, but like if you
Yep.
use an app like Clearia or Yucca or EWG to walk through Target and to try to find hair products that aren't like toxic, like good luck. And if it is non-toxic, it probably doesn't work. So
Right.
it can be a little bit of a cluster to try to figure out where do I want to land with all of this. But
Right.
if you can find a way, like does vinegar work just as well as a cleaning solution as Clorox? Sometimes.
Right. Depends. Yeah.
But is vinegar not actually getting rid of the mildew in your shower, but Clorox will? And how bad is it for you to be breathing in that mildew? Like, this is just where we
Chicken or the
can't.
egg, right?
Right. We just have to kind of step back and like gather the information and then take
Mhm.
the parts that make the most sense for us. Right.
Right.
It's frustrating. It's frustrating how much work you have to do just to exist, but we can have empathy. Right. We can have empathy. We understand. And it's like until there's a better solution, that's just what it is. And
Right.
hopefully somebody who has the time and the funding, the non-biased time and or the unbiased time and the unbiased funding to do these studies, like I'm here for it. It's not me. It's not
Yeah.
me. I don't think it's you. So
Nope. You're not.
you and your
We're just in
nonprofits.
survival mode half the time, if we're being honest. Like
Yeah.
professional patients. Let me just tell you, like, there is so much to be said about, a lot of what you're talking about is like figuring out that balance, right? Like we hear the word zen a lot, right? Finding that zen within. There's a lot of times that I don't even recognize in my own daily lives that I am in that fight or flight.
Yeah.
I have no recognition of that sometimes, right? And
Hmm.
then it can be someone that I see, whether it's my therapist or whether it's my physical therapist, who's like, you're holding on to that really tight. And it's interesting because I was seeing my went to my pelvic floor physical therapist and I was in a lot of pain and she's like, "Okay, I'm going to have you." It was something very simple, like the way I was lifting my leg or whatever. She goes, "You realize that you tightened one side to move the other in a way that was counterproductive, right? Like
Hmm.
you're expecting that pain right now." And I didn't think of it that way. Like it wasn't something that I was cognizant of. And that's why I think like when you're pairing this physical therapy side, the manual therapy, whatever that is, and also like it's okay to go talk to your therapist about it too. Like this is what's happening in physical therapy. I'm really struggling, but I don't know where it's coming from. I think there's a lot of healing that I have done through that avenue of like recognizing those patterns and then kind of addressing them twofold. And I think sometimes that's where the healing really comes in and where it's been helpful in my physical therapy when I do
Hmm.
that therapy, because then I'm able to identify why some of these things are happening from the cognizant part of my brain now, not just like a reactive part, you know? I think
Hmm.
that's what's really hard for a lot of patients is we get so stuck in I'm just in pain. And if you're not seeing the right person, sometimes they can't identify why. It just is like this hamster wheel of like, we keep trying the same things, or I'm going to try something slightly different to get a different result and nothing changes. Maybe we have to switch up our approach and combine that. I always say, I don't know if there's ever been an episode I've not talked about having a multidisciplinary approach because
Yeah.
it truly is multidisciplinary. Like I really truly will stand by this. And I'm a broken record at this point. I know. But that we have to address all of it
Yeah.
because there's not one avenue that's going to be helpful. And that's why I think like pain generate. And the other thing, maybe you can speak to this too. Something that I think is interesting is that sometimes I will address one pain generator and think that I'm good. And then another one pops up. It's like my trainer calls me a little onion. He's like, and I tell him, I'm like, at least I'm sweet. I'm a sweet onion. But
Yeah.
I like uncovering those layers. And I think a lot of that is those years and years of delayed diagnosis, failed treatments, and not understanding the disease and all of the subset diseases that kind of
Yeah.
followed after, you know?
That, and I think there's just also the bittersweet, which I know there's people that aren't gonna like me saying this, but there's also just the bittersweet concept of being a human.
Yeah.
Like, people without pathology still have stuff come up,
Yeah.
So it's like, is this my endo? Is this my Hashis? Is this my PCOS? Is this my EDS? Is this my MCAS? Is this my,
Hmm.
or am I just existing on a planet with gravity? Like, we don't know. And so it's like, and I think that's why having some gaining information or having somebody that you can dialogue with when you're like, oh, like,
Hmm.
OMG, what am I going to do about this? But not, so, and I tell people this, I was like, not every pain has to be processed. Like,
Right.
as a physical therapist, my rule of thumb, because I'm perfectly capable of hurting myself or getting
Yeah.
tweaked, or getting a crick in my neck or whatever. And so if I say I wake up with a pain, I'm like, okay, I'm going to breathe
Mhm.
and I'm going to say, I'm in pain, but I'm not in danger.
Mm.
And that's a little bit of cognitive behavioral therapy tips,
Yeah.
right? Sometimes when we're really retraining a pain pattern, we'll say out loud 7 times, I'm in pain, but I'm not in danger. I'm in pain, but I'm not in danger. I'm in
Mm.
pain. Not try to gaslight yourself, but just to like ground yourself, right?
Right.
So because we're not in danger.
Right.
My facet joint is being stupid. That's what's happening, or it's like part of my vertebra is being weird. So there is no danger. So I'll pause, be like, okay, this is what it is. And then I'll get up and I'll move. I'll do
Mm.
therapeutic movement and just do some movement that's there's a difference between sharp shooting pain and like dull achy pain, or
Right.
like, hey, that's a stretch. So find a pain-free or an acute pain-free or a acute pain-free range of motion and just kind of like, no, that's not good. But if I do this, I'm okay. And if I
Mhm.
breathe while I do that, and maybe I can add some arm motion in, like, hey,
Mm.
like either in a few hours it's going to go away because some inflammation probably built up and I probably need some time for that inflammation to get out of my system. And
Mhm.
so after about 3 to 5 days, if I'm still really like struggling with it, then I might ask one of my coworkers to be like, "Hey, like can you like hook me up? Like either throw a
Yeah.
dry needle in there or like give me a little pop or just something to disrupt the nervous system, right?
Right.
So that the movements are more effective. Or I'll pop into one of my chiro friends and just be like, help,
Yeah.
I tweaked myself. And then you just go about, you just kind of go about your day because we all are going to encounter things. And then the kicker, the other thing that is just like awesome about the delayed diagnosis is that typically you're in your like late 20s, early 30s. And then guess what's around the corner? Perimenopause.
Yep.
So it's like, is this endo or is this perimenopause? Like, I don't know. Or am I just being a human? And
Yeah.
so I think it's like I'm not going to call it the ability because really it comes with repetitions in life of experiencing pain is you just kind of have to be able to step back and
Mhm.
just what is the most important question? I am not in medical danger. My life is not in danger. I am not about to have a heart attack. I am not having a stroke. I am not hemorrhaging.
Yeah.
So what's the next tier? What's the next level of triage when it comes to pain? And
Right.
then, what's in my toolbox? What
Mhm.
has my therapist taught me? When I go to lift my leg, do I need to forcefully exhale as I lift to kind of counterbalance that pressure? Because
Right.
a lot of my patients, whether they're endo, low back, ankle, shoulder, oh, when I moved it hurt. Okay, let's do that again. But before you do, I want you to forcefully exhale through your mouth and then start to move.
Mm.
And that creates that pressure system. We're not holding our breath, but we're just
Right.
we're engaging our core to help support our physical body. And then so again, it's like number of reps you get because we're gonna have moments of pain.
Right.
So how do we manage it? Or like, oh, I'm driving down the tollway and I've been clenching my jaw and my butt
Yeah.
like for the last 20 minutes because people are psychopaths when they're driving. Before I jump, my radio is on like 1,000% volume
Mm-hmm.
and I'm sipping on my iced coffee.
Yeah.
Before I get out of the car, do I need to pause, turn the ignition off, turn the radio off, put my coffee aside, and do some deep diaphragmatic breathing
Mm.
to bring ourselves back down to baseline or to neutral? And this is where I'm going to say, like, yes, before I had my excision surgery, and a lot of other people that I work with are the same way. Sensory sensitivity or noise and light sensitivity, it's huge, right?
Right.
So for me, I know I'm having a good day when I can listen to the music on blast.
I don't
If
listen to much
I'm
music.
I hate music, but like maybe one day a month I like music.
Right.
Otherwise, I am just like it's like
Overload.
opening and closing a drawer of spoons, and it's like
Yes.
makes me scratchy. So I just don't, I'm like, okay, podcast on low to make me happy, or just don't listen to music, or just don't listen
Yeah.
to anything and reflect. So, like, and this is not just me, this is again like clinical
Mm-hmm.
experience. I see this with my patients too, but like sitting under a fluorescent light for an hour, no way. That was never gonna happen. But then you take that high volume of inflammation out, and your nervous system isn't like WFT, bro. Like, what's going
Right.
on?
Right.
We actually have a chance of grounding.
If this episode resonated with you or helped something click, don't stop here. In part 2, we'll explore practical ways to upregulate your parasympathetic nervous system, tools to support your body, calm pain pathways, and create relief when surgery isn't an option. This is about giving your body more safety, support, and room to heal. So until next time, continue advocating for you and for others.